Hi, I'm Dr. Martin Rutherford, back again with our Functional Medicine Back to Basics series. I'm Dr. Martin Rutherford, chiropractor, functional medicine practitioner, clinic director here at Power Health in Reno, Nevada. And today we're going to talk about, we've done history, there's a series for both some of you who just, for some reason, decided to watch a video on testing. We've already done a general overview of what functional medicine should look like. We've done something called Obstacles to Cure. We have done the history and the application to a functional medicine practice versus a medical practice. Same thing with the testing. We've done testing, functional medicine practice versus a medical practice as far as the exam testing. And today we're doing lab testing. There's a lot of lab testing that you can do. There's a lot of specialty testing that depends on who you're treating, what you're treating. But I'm going to go over the core of testing today, and I'm going to try to make it clear what the confusion is out there relative to lab ranges. And also, I'm going to walk through kind of a general overall basic testing test list of tests that I choose from to run across the board on so many of our patients because it's relevant to our patient population, and our patient population is chronic pain, autoimmunity, pretty much anything short of cancer that comes and won't go away, essentially. So that's what we're going to do today. And I'm going to start off with lab testing. One of the things that propelled functional medicine into the lexicon, into the conversation, was the changing of lab ranges. Now, when you go to your doctor, and you get a lab test, and the lab test has what they're testing. So it'll say glucose, and then it has the result. In this particular case, it's 94, and then it'll have something where it's a flag, and that flag will say high, or low, or normal. Okay, and then that flag is usually relevant to the range that they say you should have for glucose. So in here, the range would be 65 to 99. All right. And so if you're in that range, they would say nothing. If they were above it, below it, the flag would say high or low. Okay, so that's pretty basic. I have a feeling most of you are pretty familiar with that. The problem is when we started doing this, and we was a group of doctors that I was involved with a long time ago, and we were on a board together, and we shared information, and the problem was that, as you've already heard, everybody comes in here, and everybody probably comes into most functional medicine practice, comes in with lab ranges that are normal. There's nothing wrong with me. I had two yesterday. One's got polycystic ovarian syndrome, and the other one probably has Graves' disease, which is a fairly serious thyroid problem. But yet, both of them had normal ranges. They all had the labs. They had all of the symptoms of these conditions, but their lab ranges were normal. So what do we do with that back then? Well, there's a gentleman named Harry Eidner. He is a biochemist out of Biotics, and Harry is a pretty bright guy. And Harry spent, I believe, 10 years taking all of the pathological lab ranges and shrinking them down until they started to look like the patient sitting in front of us. If the patient sitting in front of us has had a polycystic ovarian syndrome, maybe they're losing their hair, maybe they're overweight, maybe they're having bad periods, hot flashes, too lengthy periods, too short periods, anything, too heavy bleeding, too little bleeding. They can't get pregnant, they can't carry to term, yet all their lab tests are normal. Okay, so Harry spent a long time looking at an awful lot of lab tests and bringing them down until this lab range is the lab range that says there's a problem here. So for example, in the example I just used, glucose. In this lab here in Reno, Nevada, This lab's range is 65 to 99 for your glucose. Harry found that once you get to 65, your brain is practically dead because glucose is the main nutrient to your brain, and if you lose too much glucose, you're there. But that's the normal range. Interesting. So Harry says, from all of the data that he and numerous doctors collected over a period of, I think it was about 10 to 12 years, that it should be 85 to 99. Now, that's now called a functional range. Okay, so in other words, the vast majority of ranges were tightened. There's a few that were widened, and each one was done so to reflect the patients that were sitting in front of us. Now, the range that comes from the medical community is usually designed to pick up pathology, and frankly, it fits today's medical model. And I'm not anti-medicine. I'll get that out of the way. Okay, as you'll find out as I go through this series. But those ranges are for pathology. The medical model, the insurance model, the diagnostic code model, all of these models are based around pathology. I'll give you two perfect examples. Dementia, people who have dementia, there's like 7 ranges of dementia and Alzheimer's. There's like 7 ranges of Parkinson's disease. There's and it's seven different stages, not ranges, 7 different stages or something like that. Kidney disease, there's depending on which diagram and which rating system you're looking at. There's either 4 or 5 stages to kidney disease function. In all of those, in the medical community, the model is to wait until you start to see all of the symptoms in that they're allowed to look for in that person, and you must have the damage. In other words, like in Alzheimer's, Parkinson's, you must see the Lewy body damage in the brain. You must see on this MRI, you must see these white spots, okay, or the alpha-synuclein for the Alzheimer's, or if you're talking about the kidney, I mean, the kidney, they just keep looking at the bun, the creatine rate. They just looking at the kidney markers. But those of you who have kidney problems know what I'm about to say is correct. With the kidney, it's pretty much wait until there's so much pathology and it stops working, and then we'll put you on dialysis. So the point is, the medical model is built around kind of 2 oddly different things. One is like acute, come in, you have an acute bacterial infection, acute viral infection, kill the bacteria, get it under control as quickly as possible. On the other end, for chronic problems like walk in here all the time, it's wait until it's so far gone, not because they want to, but because that's the model. The model is to wait until we can see something on the MRI, see something on a CAT scan, and then we'll treat it. These ranges reflect that. You can have prediabetes for 10 years before it actually shows up in your medical model ranges, okay? And I should use the term pathological ranges. But in the meantime, you're having irritable and shakiness, you get tired after meals, you get irritable and shaky if you don't eat anything, you're putting on weight, you can't get rid of it, you have all of the symptoms of high and low blood sugar symptoms, craving foods, you eat food, you feel better, you eat food, you fall asleep afterwards. That's a combination of high and low blood sugar symptoms, and that's what people usually have, insulin resistance. They'll experience that for 10 years before it gets into a pathological range. And what is that pathological range? It used to be diabetes type 2. Now, if you look on these tests, they actually have a pre-diabetic range. But still, it takes 10 years to get into the pre-diabetic range. So I have a patient sitting in front of me. They have small fiber neuropathy. One of the most common causes of small fiber neuropathy is prediabetes, but their numbers are normal because they're using the pathological range, which more or less is for diabetes, okay? But they're not getting treated because it's going to take 10 years before it gets to diabetes. And at that point, you got numbness, your feet are starting to turn blue. And now the doctor will say, okay, let's do a nerve conduction velocity. And hopefully that shows something. And if it shows something, they'll give you gabapentin. But that's pathological ranges. And functional ranges, you're picking things up, hopefully, before it's creating the damage that becomes permanent or the damage that becomes irreversible. You're picking up abnormal function. And you're doing that by looking at it earlier. And this glucose range number is a perfect example. I mean, 65. By the time you get down, the range in the medical model, in the pathological model, is 65 to 99. The range in the functional model is 85 to 99. So if you dip below 85 and you're 80, your doctor's telling you normal. We're looking at your symptoms and you're getting irritable and shaky. You're nodding off. You got sugar cravings. We look at that and go, in the functional range, you have low blood sugar, and we need to treat you for that. And we use a combination of the history forms that we talked about in the last couple of presentations to see what that patient's symptoms are every week, because we will actually go by those symptoms and by the functional ranges. And it can get pretty complex in trying to figure out what's wrong with somebody. Just to give you an example, I'll stay with blood sugar. I have this happen all the time because blood sugar, as we're going to talk about in the next couple of presentations, is foundational to you getting better. If your blood sugar is not pristine, it creates a lot of abnormalities throughout the body: thyroid, brain, anxiety, inability to sleep all through the night. It does a lot of bad things. And so you're trying to fix stuff and it's not working because your blood sugar is off. Okay, you're trying to take an herb for staying asleep, but it's not working because your blood sugar is dropping in the middle of the night. Why? So we need to know about blood sugar, but it's hard because I just got done talking about blood sugar and saying you could be pre-diabetic for 10 years before it shows up. So what we do is, in blood sugar, we actually have people take their blood sugar 2 hours after they eat every meal. And some of our patients are eating 6 times a day. Some of them are eating 3 times a day. They take it after every meal. And then that gives them a number. Then we look at their assessment forms that we have people fill out every week. And those are the symptoms. Remember, the symptoms could be there for 10 years before you have a problem. And then we look at the blood panel. We regularly have this happen, where the blood panel says they have high blood sugar. The blood glucometer that they're taking says they have low blood sugar, and their symptoms say they have something else. Preferably, in that case, it would say they have insulin resistance. What we would do is we would treat the insulin resistance, because the symptoms, believe it or not, in that particular case, are more accurate. And we've had just the opposite. We've had the home test tell the person that they have high blood sugar. We have the A1C glucose telling them they have low blood sugar. And then we have the symptoms saying high blood sugar. Without getting into that at length, they're probably insulin resistant too, moving from high blood sugar from low blood sugar to high blood sugar. So I'm not trying to confuse you. I'm just trying to show you pathological ranges versus functional ranges. And I'll just say this, okay? Cleveland Clinic is now doing functional medicine. They are adopting many of the functional ranges that are still not being adopted in labs around the country. Mayo Clinic has adopted the functional ranges for autoimmune thyroid disease. It used to be, in the pathological range, it used to be 0 to 100. For as long as I've been in functional medicine, it's been 0 to 9. So everybody from 9 to 100 is being told, you're fine. They're not. But they have all the symptoms of an immune attack against their thyroid, 20 out of 20 symptoms, but they're being told they're normal because they're 40. And now the range in a lot of the labs is 0 to 32 on that, for those of you who may have Hashimoto's and go, no, those are wrong numbers. Now they're 0 to 32 in a lot of labs. We have a hospital in town at 0 to 32. We have another hospital in town at 0 to 9 in the pathological range. So they're coming down to these ranges. And I think it'll continue to do so because they're finding it more effective to be able to treat people before the damage is so far gone that you can't do anything for them. So two subjects: why are the ranges different, and the story in the labs. Okay, the ranges are different because each laboratory that you go to really does kind of a bell curve of all the people that are coming in, and then they kind of cut off the ends, and then they use the ranges that patient population has for their pathological range. And whichever they're embracing, if they're embracing 32 is the range, or 0 to 34 is the range, or 0 to 40 is the range, or 0 to 16 is the range, whichever one's the closest, when they do that, that's the range that they use. That's why they differ from lab to lab. But you'll notice that these numbers tell a story, okay? We just got done talking about blood sugar, and we got done talking about how you have to really, they tell a story and they're not accurate. I actually was at a seminar this year in which the doctor, whom I have had a lot of respects for, said the only truly accurate blood test out there is the strep test. And I raised my hand and I said, "You mean like in infectious diseases?" He said, "No, I mean like period." He said, "That's really the only accurate test out there." I think I can embrace that based on looking at thousands and thousands of labs and seeing how they are, how off they are. And you have to understand the body is a mechanism of millions and millions and millions and millions and millions of chemical reactions that are going on all the time. Many vicious pathways, vicious cycle pathways. And so the medical model, again, goes back to, we're going to target one particular aspect of your physiology, and that's how these tests are used in the medical model. You have something with your kidney, then we're going to, well, I just used that as saying they're not going to do much for your kidney, and they're not, but they might do something for your kidney to try to ameliorate it until it fails, and then you're put on dialysis. But the functional model is not to wait for that to happen. The functional model is to look at this and look at vicious cycles and systems. So the functional model is to look for the story in these labs. So for example, if you have somebody that has a heart problem and they do all these cardiac, I forget which one now it is, there's a lab, it's like Harvard has, Boston, it's Boston has a cardiac screen that a lot of doctors are doing now. And then it's give you statin drugs if you're a doctor, or it's give you CoQ10, or it's give you whatever that for your heart. But here's the thing, okay? In functional medicine, we don't even really have a section on our metabolic assessment form for heart, okay? And I was just looking at a lab this morning of a gentleman who's had multiple heart attacks. He's on statin drugs, but we're not going to treat his heart because that's not functional medicine. Functional medicine is, why did your heart clog up? The reason his heart clogged up is because there was inflammation in the arteries in his heart. And he may or may not have had a high, what's called C-reactive protein. C-reactive protein is an inflammatory marker for the heart, but hopefully he did. But if he has a high C-reactive protein, you know there's inflammation in the heart. The medical model is, let's do something and give something for that inflammation. Let's go in and do that. And the functional model is like, whoa, okay, what's causing the inflammation? And interestingly enough, you will find that those inflammatory markers they can be caused by so many different things. And one of the things that can cause it is blood sugar. So I'm looking at a heart problem, I'm going to be looking at that person's blood sugar. Oh, wonder of wonders, the gentleman has blood sugar problems. Okay, he has an A1C of 8, which means he's got diabetes type 2. Okay, well, why is that important? Because diabetes actually will create the inflammation, first of all, and then it causes you to not, your insulin doesn't work right, it causes you to not get your blood sugar into your cells. It's got to go somewhere. It breaks down into triglycerides. I could spend an hour talking about why your cholesterol panel is not about cholesterol or triglycerides or low density lipids. It's about blood sugar. If you have high triglycerides and everything else is normal, you're getting blood sugar problems. And you can tell that from the triglycerides. You can tell you're getting prediabetes years and years and years ahead of time. So, so the point being that there's a story there. It's the heart, it's the inflammation, it's what's causing the inflammation. The diabetes is probably what's causing part of the inflammation. The diabetes is actually is causing the high blood panel. So if you have high cholesterol and you have a bad heart, what are you going to do? Well, in the medical model, you start treating, basically, you usually give a statin drug to make sure that this doesn't clog up, and then you start treating the cholesterol. Wrong. You would treat the diabetes. And when you treat the diabetes, the cholesterol panel would get better, the inflammation would be down, and if you've caught it in time, you're done. So this is functional medicine versus pathological medicine, and this is how you read the labs. So I do that. That took a little bit of time, but it's a challenge in here when people come in and I go through the functional labs and they go, but my doctor said it was okay, and I want to say, I know your doctor said it okay, but you still have your problems and you're here. So so let's talk about functional norms. So some of the interesting things, I could walk through this whole lab process and go through all of these labs, and I'm just going to hit some interesting things here that might help you to assess your cases better. The genesis of this whole series was that Power Health has like 600 or 700 hours online. If you look at powerhealthtalk.com, you name it, just about anything that comes in here, we have a presentation on. Some of them are short, some of them are very lengthy. I think there's over a couple of million views on them. They're well received. We get a lot of good feedback. But people say, but you're not telling us how to get better. So I'm walking through this whole procedure to tell you why we don't do that, but also to help you to know what should functional medicine look like if you walked into it. If you're really walking into it, you want to get a real functional medicine feel when you walk into an office. And frankly, there's no discipline board or there's no regulation board on functional medicine. So anybody can call themselves a functional medicine practitioner. I'm going to walk through some of the more salient things I like that I think you might be interested in. And then I might go through some testing that I keep in mind on every patient that walks in the door. So this is actually a test that we do on everybody. It's a test that's extraordinarily comprehensive, and it really is designed to tell us everything that we need to know about the chronic patient relative to inflammation and autoimmunity. These are all standard lab tests. None of them these are not specialty tests, and I'm not going to get into specialty tests today like Lyme testing and stuff like that. It's controversial, and frankly, the vast majority of the time, you don't need as much of that as you need of this. So the A1C, so the blood sugar testing is very important because of what I just said. Okay, it'll take you 10 years before your blood sugar becomes looking like prediabetes. And the range for prediabetes is 5.7 to 6.4. We like to see it below 5.4. And I'm going to give you some clinical pearls as to why we look at this. So the functional range is below 5.4, and above 5.4 usually indicates there's a little bit of something called small intestinal bacterial overgrowth in our patients. And these are things that we're looking for because that can cause a lot of problems in somebody. Most of you who are watching this probably have heard that. And this is a way of finding it. The testing for it isn't great. It's okay. The SIBO breath test, but this is kind of a cross-check on that. Uric acid is a marker that we use for, most of you would know, for gout. Our range is much more contracted, but if we see it in the functional range, we use it as an inflammatory marker. We know that we are inflammatory hunters. That's what we do here. I mean, this is This is three-dimensional medicine where you're looking for the story, you're looking for the vicious cycles, you're looking for the feedback loops. You're not just looking for something to drop a pill on. All right, you're looking to change physiology here. So uric acid, so we're looking for anything that gives us hints of inflammation. There are kidney markers here which we look at. Sodium and potassium for us is more of an adrenal marker. If it's in the functional range, we'll do adrenal testing, some adrenal specialty testing. But potassium and sodium chloride are controlled at the adrenals. They can tell you a little bit about the kidneys, but for us, those are adrenal markers. Protein and globulin, people will look at those for disease purposes. The medical pathological model will look at those mostly for disease purposes. Those are large molecules that should not get through your intestines, your intestinal barrier. So if we look at that and we see that they're either high or low, it's an indication of intestinal permeability, leaky gut. So, and a lot of people come in here from a lot of different, what's the word I'm looking for, abilities to, a lot of different layers of economic abilities, okay? And if testing is going to be a financial issue, a lot of times you can work largely off of this test because there's a good test for specialty test for leaky gut out of a lab called Cyrex Labs, and you can do it. It's $120. It's not entirely unreasonable, but if the person is on a budget, shall we say, then you can look at this protein and globulin and go, you know what, you probably have leaky gut. There's something in here called lactic dehydrogenase. Lactic dehydrogenase is used for in the medical profession and in the model. It's used to find disease in your kidney, in your liver, in muscles throughout the body, in different structures throughout the body. It's a sugar-based molecule. We use it to look for blood sugar. Under 150 is, and the range for the medical pathological model looking for these pathologies is 120 to 225. Let me see, is that correct? Yeah, 120 to 225. And we like to see it above 150, okay? If it's above 150, we're fine. If it's below 150, functionally, that person has something called reactive hypoglycemia. Another blood sugar marker that we can use, because the blood sugar markers can be your blood sugar is affected by so many things. We're going to talk about that. It's affected by food sensitivity, stress, sleep apnea. So it's really hard to get exact blood sugar numbers. Going back to the fact that he said that the one gentleman said the strep is the only real solid number. This is another indicator that the person has a blood sugar problem. Liver, there's liver enzymes, AST and ALT. The medical model is 0 to 40. We are 0 to 25. It tells us if the person has a fatty liver. The medical model waits until it's like 0 to 100 or until you have a real pathology there, and then they start doing some pretty aggressive stuff. In our world, once we have it over 25, we know there's a fatty liver there. Functionally, that means you're not going to clear your liver properly. You're not going to clear your estrogens properly. You're not going to all those nice fatty vitamins that you're taking, the fat-soluble vitamins A, D, E, K, you're not going to be processing those properly. You're not going to get in the system. In our understanding, above 25, between 25 and 100, the medical model doesn't care. They're looking for pathology. We're looking for it to work, okay? And so that helps us a lot. Same thing with the gallbladder. Iron, a lot of medical models don't include a ferritin in their iron panels. They should. Ferritin is extremely important. If your ferritin's high, your iron, and you don't need to go into the chemistry of this. The iron in your system is going to be low, and ferritin is massively inflammatory, but most panels that are dictated by insurance never run it. So the point being this, if your ferritin's high and you got inflammatory issues, and they don't run it, and they don't know you have it, and they just run an iron panel without it, and your iron's low, they're going to give you iron as though you're anemic, and then it's going to, and ferritin is high because it's not breaking down. It's something in your cells that's not breaking down. It should break down. into iron, which goes into your bloodstream. If it's not breaking down, it's going to get more and more. If it gets really, really, really bad, they call that hemochromatosis. If you've ever seen somebody with hemochromatosis, they are in bad shape. So ferritin's important. We just talked briefly already about the cholesterol. In our world, cholesterol is like almost never the problem. Cholesterol is like the good guy. Cholesterol goes in and it patches up bad things. Cholesterol goes in and goes into your system and makes all of your hormones except for your thyroid hormone. Cholesterol, if somebody comes in here and they're polycystic ovarian syndrome and they're vegan and they're vegetarian and I honor that, and I honor philosophical beliefs, but the reality is cholesterol makes all your hormones. It's kind of hard to get that person to be able to get their hormones right so that they can have babies if they insist on being vegan. Even because even those people, you can give them essential fatty acids to get their cholesterol and triglycerides up, and it's hard to do if you're not able to do that. So but the main point is, cholesterol is not the bad guy. Okay, what cholesterol does in heart attacks is it goes in and it patches up the damage from the inflammation that, in the example I used before, was actually caused by the diabetes. If your cholesterol is really high and your inflammatory markers are really high, like something called, you should get, if you got chronic problems, you should probably always get a C-reactive protein and a homocysteine run. If they're high, now your cholesterol matters, because now if you got high cholesterol, then you got a better chance of having a stroke or a heart attack. But if your inflammatory markers are under control, your cholesterol could be 500. I know that's heretical to say that, but you're correct. You could be out of the range for sure. And it's okay. So cholesterol in our world is really more of a blood sugar marker, or the lipid panel is more of a blood sugar marker, because the blood sugar breaks down when it can't get into cells, and it breaks down the triglycerides, and then that whole panel starts to look bad. Thyroid, all I'm telling you here on thyroid is you should have 1, 2, 3, 4, 5, 6, 7, 8, 9. There's 10 markers you should run. Okay. And your thyroid panel should look something like this. Okay, your thyroid panel should look like that, not like this, not just a TSH and sometimes a T3 and a T4. There should be 10 markers there, and then you can tell the story of thyroid. Now, thyroid's a whole thing unto itself. You should look on our website. You should look on Power Health Talk. We have so many thyroid presentations there. Thyroid has to make the thyroid hormone. It has to then get somewhere, and the way it gets there is on these proteins. These proteins can be affected by blood sugar, stress, birth control pills, steroids. Those of your guys who are taking testosterone, steroid hormones, and stuff like that, that can all screw up the ability of your thyroid hormones to work properly. Then it has to get to the liver, so you have the liver enzymes here. Then it has to get to the gut. Then we looked at leaky gut that you can see in here. And then it has to get to your cell sites. And there's a lot of drugs that can stop that from going in, so you have to review the person's drugs. You cannot tell relative to if that's happening or not unless you look at all of these markers. And you need to know all of that to be able to assess somebody's thyroid and, frankly, their overall physiology. Thyroid is almost more a reflection of what's going on in your entire physiology, and you need something like this to be able to understand that. We already talked a little bit about Hashimoto's. Basically, the thing you need to know about Hashimoto's is the lab range right now, and the lab range I think is going to become the standard, is 0 to 9, and half the labs out there are 0 to 34. I've seen with 0 to 20. I've seen with 0 to 16. I haven't seen too many 0 to 60s, but I've saw one within the last couple of weeks. So it's pretty wild. It's like the wild, wild west out there when it comes to Hashimoto's. 0 to 9. And the Mayo Clinic is using this standard right now, okay? Vitamin D, the lab range, just interesting, lab range is 30 to 100 here. I just saw one of our old keys to success where one of our doctors said that they didn't want it over 70, which was correct at the time. There are places in Europe, South America, where the lab range is 100 to 300. And we just had a patient from Hong Kong, and their lab range read 0 to 222. So lab ranges for vitamin D are all over the place. Okay, we like to see vitamin D up around that 100 mark in our patients. I can go into vitamin D sometime if you show interest in that. It's a big deal. Vitamin D is a big deal. If your vitamin D is below this lab range, you probably have autoimmunity. And that's something that we discuss again in a lot of these videos that we've done already on powerhealthtalk.com. White blood cells, there's a CBC with white blood cells, so you're looking for autoimmunity, you're looking for anemias. We're going to talk about oxygen. Anemias are going to be part of it. Those of you who have been told you have anemia forever and ever and ever, but just don't worry about it because it's low. It just must be normal for you. It's not normal. It's usually chronic disease. It's usually chronic inflammation. And you have to have oxygen getting to your extremities and your brain and your hands and your feet and everywhere for you to. It's one of those foundational things we're going to talk about a little bit more in the upcoming episodes. And so anemias are very important to us. White blood cells, we have a lot of people who come in here and say, my white blood cells have been low forever. They've done all kinds of testing. I don't have any pathologies. Again, the medical profession is looking for pathologies. They want to know if you have polycythemia, leukemia. They want to know, if you have high red blood cells, high white blood cells, or low. They're looking for that. By that time, your blood cells have been doing damage to you for a long time. So chronic low white blood cells usually mean, if they're not pathology and if they've been ruled out, they usually mean either chronic inflammation, they may mean autoimmunity, they could mean a chronic viral infection, a chronic bacterial infection, like an Epstein-Barr virus or cytomegalovirus or something along those lines. Their eosinophils are interesting on your CBC. Eosinophils can be a check as to whether you maybe have parasites. If eosinophils, this is functional, okay? Eosinophils here, there's not an established norm in the medical profession. For us, if it's over 2, then we're looking for allergies, type 1 allergies. Like here it would be sagebrush. We're like right at the foot of the Sierra Mountains here, and then from there on it's desert, and so it would be that. But eosinophils can be a good marker for parasites. Have you been out of the country? Have you been out in the woods? Have you been drinking the water? Do you have diarrhea? If the eosinophils are over 2, then you should do then you would do a parasite test. Okay. There's neutrophils and lymphocytes. A lot of doctors don't really. They do some interesting testing for viral infections and stuff, but it's not all that accurate. You can look at your neutrophils and lymphocytes here, and if they're like more than 40 points apart, depending on which one's more, will tell you what's going on. The one I'm looking at in front of me actually has a bacterial infection. Their neutrophils are viral infection. Their neutrophils are 25 and their lymphs are 71. Lymphocytes are representative of viral issues. Neutrophils are representative of bacterial issues. They have much more. It's more than 40. Then they have a viral infection. And in fact, this person has Epstein-Barr virus. So that's that. We do a CBC, pretty basic. We do a urine analysis, pretty basic. And then the rest of our testing we do is more specific to the patients. But they're not if we have a female that has polycystic ovarian syndrome, then certainly we'll do hormonal panel testing for that. If we have a patient who comes in that's andropause, a male, overweight, and high blood sugar and high blood pressure and testosterone low and all that, we'll do that type of testing. We do some specialty. We do a lot of specialty testing, but the ones that I think are more basic to the patient population out there looking for what can I do for myself, okay? And most patients should check their essential fatty acids. Essential fatty acids are foundational. We're going to talk about that. The vast majority of patients I check for essential fatty acids are low. We get them up to normal, and just that foundational issue alone can change a lot of things. Essential fatty acids have a lot to do with a lot of stuff. Blood sugar, inflammation, brain function, mood, a lot of things. Skin, a lot of things. That's a lot of my patients have those things. And they think it's, like for me, I mean, full disclosure, I had dry skin forever. And I thought it was my Hashimoto's, and had my Hashimoto's under control. And then I finally tested my essential fatty acids, and they were almost non-existent. And now I have healthy skin again. So antiparietal cell antibodies, the hydrochloric acid in the stomach is massively underrated. I mean, it does so many bad things if you don't have enough hydrochloric acid. So we usually run antiparietal cell antibodies on almost everybody that walks in here to see if they have an immune attack against even if they have a low hydrochloric acid according to their symptoms, then we're going to know that is going to cause a cascade of problems throughout their intestines. And so we run those. And antiparietal cell antibodies is an autoimmune problem. We want to see, can we fix that? Or is this something they're going to have forever and they're going to need these supplements forever? We run those. Another test we run on everybody is called the DHEA sulfate. It tells us, it gives us a big heads up on the health of the adrenal glands. Those of you who are in the alternative world know you don't fix the adrenals, you don't fix anything. That's one thing we do on just about everybody. Let's see what else. Most of the rest of our tests are specialty tests that we do based on the cases. So we use something called Cyrex labs for most of our autoimmune testing. There's some other labs that are coming out now. I'm not a big fan, just for those of you who are Lyme people, I am not a big fan of Lyme testing. I have actually been to seminars where the people who do the IGeneX test stood up there and said how bad it was. But it's the only test we have, so that's the test we have to use. If you want to know about Lyme, look at PowerHealthTalk.com and look at our Lyme presentation. I think it gets very, very, very positive reviews from those people who have not kind of drank the Lyme Kool-Aid, is what I usually the way I put it, relative to the whole have to take antibiotics for years and all that type of stuff. So Lyme testing is a whole different animal. If you have anxiety, I like to see zinc and copper. Your zinc should always dominate your copper. A lot of people who have anxiety. There's a lot of other things that go into anxiety. Thyroid can go into anxiety. Hashimoto's can go into anxiety. Low blood sugar can go into anxiety. There's a ton of things that can go into anxiety. And I'm going through all this for all of you who say, why don't you tell me how to get better just by telling me how to get better. So if you have anxiety, zinc's a good thing to do. There's some specialty tests. If you've had your anxiety for your entire life, there's a good test out there. But it's a specialty test called the Genomind test. There's a lot of other tests. I mean, we probably use, I don't know, we probably use 25 or 30 other tests, depending on the patient and what they need. And those are specialty testing. There's the whole stool industry out there is vying for who's the best test out there. And to me, it's between Genova stool test and Diagnostic Solutions stool test. But that's all here and there. The main thing is the understanding of what I just went through with you. What I just went through with you was to tell you, here's why the functional norms are important, because we are looking at you functionally. We are looking to put your physiology back together. By the time you wait until it's pathological norms, yes, you can use those lab ranges, and you don't know how much damage is there by the time the person's in diabetes type 2, and you don't know how much damage is there by the time they're in stage 3 kidney function. But so you may still be able to recruit that. But you build off of the whole picture that is presented by these, because you're looking at the person's entire physiology. And you'll notice I kept saying, this means inflammation. This means inflammation. This means that that their blood sugar is off, even though that's not a blood sugar marker. So we're looking globally. That's functional medicine testing to the best I can. I mean, I could spend, like the book on this, I'll just pull it out of here. This is the book. All right, this is the book. This is the initial. Okay, just as one. This is the apex one. Okay, so this is one of the supplement kind. This is the initial book on the basics of reading these lab tests. There's so much data in there. It would take 3 days to go through it. But I'm not looking to make you experts on this. I'm looking to help you to understand it so that when you go into your functional medicine doctor, you understand what they're trying to accomplish. So that should wrap it up for today. And then next week, we are going to start into the foundation. Now we're going to start into treatment, okay? And I go back to the fact that when I first got into this, nobody knew what a functional medicine practitioner was. People would come in here out of total desperation. It was an interesting experience. Some of them would really kind of like abuse you. Like, what do you think, you're a medical doctor? And my thing would be like, well, what are you doing here if you don't want to know what I'm talking about? And it was like that. It was actually like that. You know, it was crazy. Oh, my medical doctor said you're a quack, or I'm going to go check with my medical doctor. So we didn't have very much going back then. Now, medical functional medicine is pretty well. It's at the Cleveland Clinic. There's several colleges around the country that are teaching functional medicine. I know my mentor, Dr. Krosian, is doing some work at Loma Linda. He just got done doing a $150 million research project, participating in it on the gut and at Harvard. So it's certainly changed since the time I've been here. And now what I'm seeing is I'm getting a lot of people coming here who've already been to functional medicine doctors, homeopaths, naturopaths. And naturopathy, frankly, was kind of, you know, the precursor to functional medicine. And yet still, they're doing a lot of the right things, but this particular patient isn't getting better. A lot of times it's because the foundational issues have not been addressed. I briefly mentioned sugar as a foundational issue. I briefly mentioned essential fatty acids as a foundational issue. So we're going to get into that over the next couple of weeks, because it's hard for you to get better if the foundation is not set. And there's certain things that just make us human beings, like proper blood sugar and proper essential fatty acids, and there's a handful of things like that. So we're going to talk about those next. So we're more or less getting into treatment. A lot of times you set the foundation and these mystery diseases that nobody can tell you what is start getting better. Okay, so my whole world is back to basics. I'm the author of a book called Back to Basics. It actually needs to be edited because I need to go, okay, I wrote this before the whole explosion of autoimmunity, but in the end, it's still about back to basics. Nothing has changed. We're still human beings. It's not magical. We just need to get back to understanding physiology. And so next week, we are going to start really getting into the physiology of autoimmunity, and by going over the very basics of what we're doing. And we'll start with oxygen next week. So that's what we'll start with next week. And I'll just let you contemplate that one a little bit. So we'll see you next week. And I hope this was helpful. And I hope it's helpful to you to help your functional medicine practitioners. And it felt like this felt pretty good. So I'll see you next week.